This is the second in a series of podcasts on the male prostate gland. In this podcast, I'm going to discuss the sequence of events leading up to my prostate cancer diagnosis, decision to have a radical prostatectomy, pre-surgery testing, the surgery event, and post-op recovery. First, let's discuss the PSA test. I've been having PSA blood tests for the past 15 years. As you learned from my first podcast, the PSA test measures the amount of PSA, prostate-specific antigen, in the blood. Elevated levels can indicate prostate cancer, but they can also be caused by conditions such as benign prostatic hyperplasia and prostatitis. There is no single normal PSA level. My PSA level started out around 3.2 and increased over the past 10 years to my pre-surgery level of 4.2. PSA levels below 4.0 are considered normal. In fact, after age 60, 3.5 to 4.5 are not a cause for alarm according to some clinicians. My GP never recommended I see a specialist. Second, let's discuss why I saw a urologist. Several things prompted me to see a urologist. The first thing was the feeling of having to urinate right after emptying my bladder. The feeling of pressure and having to urinate right after urinating did not seem right. I also was experiencing a slight tingle in the urethra immediately following urination. The tingle was intermittent. The first urologist I visited did a prostate ultrasound, a PSA blood test, and ordered an MRI. The ultrasound showed a slightly enlarged prostate, which is normal for my age. The PSA blood test resulted in a number of 4.2, which was not high for my age, but the fact that it increased from 3.8 the previous year to 4.2 was a signal that further tests were necessary. The prostate MRI showed 3 lesions, and the radiologist recommended a prostate biopsy. I changed urologist after the MRI for 2 reasons. First, he never contacted me with the MRI results. After several weeks of waiting for him to send me the findings, I checked with the radiologist and discovered the fact that I had a possible cancerous lesion. My wife called the urologist to inquire as to why he never followed up with me. His response was that it is the patient's responsibility to make an appointment and come in to discuss the results. Second, I inquired as to how he did his prostate biopsies. His response was that he did them using the transrectal approach. He told me that transrectal was the established method and very safe. I know from doing research that the transperineal approach is much better. I asked him about that, and his response was, "How do you know about the transperineal biopsy?" I'm going to explain both types of prostate biopsies next. The transrectal biopsy. In the transrectal biopsy, an ultrasound is used to guide a needle through the rectum to collect tissue samples from the prostate. Prior to having the procedure, it is recommended that the patient use a fleet enema. During the procedure, the ultrasound probe is inserted into the rectum to visualize the prostate. A biopsy needle is then passed through the probe and tissue samples are obtained. There is a risk of infection with the transrectal biopsy, as each needle passage risks inoculating the prostate with rectal bacteria, but modern techniques have reduced that risk of infection. The risk is around 1 to 2%. Recovery is relatively easy after the procedure. You can expect some blood in the semen and urine for a period of time. Local anesthesia is typically used for pain management. Patients will feel some pressure from the ultrasound probe and a brief sting when the biopsy needle is engaged. In the transperineal biopsy, an ultrasound probe is inserted into the rectum for imaging the prostate. Typically, 2 punctures are made in the perineum, the area between the anus and the testicles, and the biopsy needle is inserted. Tissue samples are taken from the sides, front, and top of the prostate. The procedure is done as an outpatient procedure and takes approximately 30 minutes. It can be performed under general anesthesia or under local anesthesia. I highly recommend general anesthesia. The transperineal biopsy has one significant advantage over the transrectal approach. The risk for infection is reduced significantly because you are not going through the rectal wall. I have several friends who had the transrectal procedure, and both had post-op procedure infections. Recovery is relatively easy. You can expect some blood in the urine and semen for a period of time after the procedure, and for several days there's soreness around the puncture sites. I'm now going to discuss the radical prostatectomy. The radical prostatectomy is performed in the operating room under general anesthesia. You will be provided with pre-op instructions by your surgeon. There are 3 surgical approaches used to remove the prostate: open surgery, laparoscopic surgery, and robot-assisted laparoscopic surgery. In the open procedure, an incision is made in the lower abdomen. In the laparoscopic approach, instruments are inserted through small incisions along with a video camera for visualization. The robotic-assisted approach is done through similar small incisions, but the instruments are connected to robotic arms and the surgeon controls their movement from a console. The robotic approach offers some advantages. You will experience less pain, potentially reduced blood loss, and faster recovery. The fact that the robotic approach uses a very high-definition camera to visualize tissue improves surgical precision, which can benefit urinary continence and erectile function preservation. During the prostatectomy, the prostate gland and some tissue is removed around the gland, including the seminal vesicles. If the surgeon believes the cancer has spread to the lymph nodes, the doctor will remove the lymph nodes and prostate. If the cancer has spread to the nerves, they may also need to be cut to remove the cancerous tissue. If both sides of the nerves are cut or removed, an erection will not be possible naturally. If only one side of the nerve bundle is cut or removed, there is the potential to have an erection. According to my surgeon, it could take months after surgery to know if you have full recovery. As you know from my first podcast, after the prostate is removed, there is a gap between the bladder and the urethra. Reconnecting them restores the flow of urine from the bladder. A Foley catheter is used for approximately 10 days after surgery to assure that the urethra heals correctly. There are some surgery risks that are very concerning to men: urinary incontinence, urinary leakage, erectile dysfunction, lymphedema, and penis length change all contribute to a patient's apprehension to have a prostatectomy. I personally did not experience any of the above complications. Day 1 post-op, I had complete control of my bladder. Some men experience problems with urinary control after the catheter is removed. Usually, men can regain control of their bladder given time. I did experience some swelling in the testicles and groin area, but that resolved after 5 days. In regard to erectile dysfunction, my surgeon recommended I take 100 milligrams of Viagra when ready to begin sexual activity. He said erections will not return on their own and will require persistence and perseverance as soon as possible after the catheter is removed. He also said it is important for men to have realistic expectations, as erections will be partial for a period of time. Also, he indicated that tactile over visual stimulation will be the norm during the recovery period. When erectile function begins to return, many men complain that they lose their erection when attempting intercourse. An erection ring can be used prior to foreplay to keep the blood supply in the penis. Check with your physician prior to taking Viagra or any ED medication. Post-op, your bowel function should return to normal within 2 to 4 weeks. If you recall from my first podcast, the rectum and the prostate are next to each other. If you experience constipation and hard stool, straining can cause bleeding in the urine. You should adjust your diet and take a stool softener for prevention. You do not want to strain during a bowel movement. If you experience bloody urine after your catheter removal, check with your physician. I did experience some dried blood at the tip of the penis while the catheter was in place. My urologist recommended I apply Vaseline to the tip daily to help alleviate the feeling of irritation. Dried blood is a normal occurrence after surgery. Bladder spasms can occur, especially at the time of a bowel movement. If your catheter stops draining, you could have a blockage and should call your physician. Urinary tract infections can occur with the use of a catheter. Your surgeon will prescribe an antibiotic to take 1 day prior to catheter removal and 2 days after. If you feel pain in the urethra during or after removal, call your physician. I experienced some burning at the tip of the penis when the catheter was in place and after removal for a few days. I was told that that is normal. It did subside gradually. A small percentage of men experience urinary retention after the catheter is removed. If you cannot urinate properly after 6 hours, go to the nearest emergency room and have another catheter inserted. Some men feel discomfort in the perineum while sitting. This is common and will resolve itself after a few months. Swelling and discoloration of the scrotum and penile skin is also common and will subside with time. You can elevate the swollen scrotum with a rolled towel or pillow to help reduce swelling. I also placed an ice pack on the scrotum for short periods of time. While the catheter was in place, I used a small bucket to place the bag in while sitting. This assures that if the bag has a leak or you fail to close the drain port properly, urine does not drain out on your furniture or rugs. You will find it easier to wear very loose-fitting pants. At night, I wore an oversized long nightshirt. You can also wear extra large warm-up pants with baggy legs. For the first 10 days until after the catheter was removed, I slept on the couch, making sure to keep the drain bag lower than my bladder. I experienced very little pain, but the abdominal wall was very sore for approximately 5 days. I refrained from taking oxycodone because it can cause constipation. Extra strength Tylenol was sufficient as a pain reliever. After a few days, I resumed walking for exercise. You have to refrain from lifting anything over 5 pounds. Golf is not advised for 6 weeks. In the next podcast, I will discuss the importance of finding a good surgeon.